Everyone, thank you for joining us. We will be recording this meeting, just so everyone knows. Thank you all for being here. This is our initial meeting for the long-term home health rule revision work group. I appreciate y'all being here. Hopefully most of you were also able to attend our prior work group, which was for the pediatric long-term home health our restart process. So that was back on the 8th. If that's something you are interested in or would like to discuss in further, please let us know. You can put your name and email in the chat, and we'll make sure you are on the next meeting. Quick round of introductions first. My name is Paul Hutchings. I'll be your host and facilitator for this meeting today. This actually works out a lot better when I'm not on mute, so you guys can actually hear me. My background, I am actually a physical therapist by trade. I came to the department 2 years ago to work on a few of the ARPA projects that we were starting up, specifically the long-term home health and private duty nursing acuity tools. Prior to that, I was working in outpatient physical therapy, had a small dab in pediatrics, and then for the past 12 years of my career, I was working specifically in the home health arena. With me today, I have Christine Merriman, who is also with the department and is our home health policy advisor, also with private duty nursing. You want to say hi, Christine?
Hi, everybody. I think a lot of you know me or have had interaction the past couple of years with me in the home health inbox or through private duty nursing.
And then also on the call, we have Cassandra Keller.
Hi, everybody. Cassandra Keller. I'm our Community Options Benefits Section Manager. My teams oversee our home and community-based services, as well as long-term home health, private duty nursing, and pediatric personal care. Thanks.
Thank you. We also have a few of the folks from the department helping out with today's meeting, helping us run the slide decks, watching the queue, watching the chat box, taking notes, include a few of the folks, and then some of our clinical team from CCQI. So again, thank you everyone for being here. We can go ahead and go to the next slide. Our mission, as we always start off with, our mission is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide. The purpose of this meeting, this initial work group, the Rule Revision Work Group is for members, family members, advocates, providers, case managers, and other interested stakeholders to collaborate with and advise the department as it reviews and updates the regulations for the long-term home health benefits. The agenda and this slide deck is already posted on our website. You can get to it. I believe we can put the website there in the chat box, so you will have access to these slides as well. And then it shows down there, section 8.520. This is the section we will be reviewing in our upcoming meetings. Next slide, please. Quick agenda for today. We've done our introductions. I'd also ask you to please complete the attendance form, which we listed in the chat. We'll put it up there a few times during this meeting today. We want to make sure we capture everyone's names and your affiliations. After this, we'll be going over a few housekeeping and agenda items. Briefly talking about the rule revision process, the goals for this work group, and then we'll getting into the work group discussion after that. Go ahead, next slide, please. Quick note on some housekeeping. Please mute your phones or your computers when you're not speaking. If you'd like to say something, if you have a comment, question, a concern, please raise your hand and unmute yourself. Again, we do have folks from the department who will be watching the queue and watching the chat to make sure I don't miss anything. Please identify yourself before speaking so we know who we're talking to. We'd love to know your name and your affiliations. Again, you can use the chat box. If you don't feel like speaking publicly, that's fine. This is certainly not my forte, and I'd much rather be chatting in a chat box. So if you'd rather do that, that's great. And again, as we are recording this, please do not disclose any protected health information or PHI. If we do that, we will be unable to post this to a live public forum, so we're unable to discuss any specific cases during this work group. And Megan, I'll get to you in just 1 second. And lastly, in consideration of everyone's time, we are really going to ask that you please keep the conversations in this meeting focus and specific to the dialogue regarding the long-term home health rule revisions. If you do have any other questions or concerns or anything else that's bothering you, you are more than welcome to email us. You can call, and I believe there's an option for a fax. I haven't quite seen that yet, but I'm sure we could get to it somehow. Yeah, Megan, go ahead. Megan, I'm not sure if you're on mute, but I'm not hearing anything. Okay. I guess we can get going. Megan, if you have anything else, please let us know. And real quick, before we get going, I just want to let everyone know that we have kind of revised the focus of this work group. Instead of doing an actual red line work today on the home health rule, we are going to be collecting suggestions, thoughts, and ideas of things that you would like to see changed. What concerns do you guys have with the current rule? Are there any parts of 8.520 that are difficult to understand, that need to be reworded or even reformatted? Really, the thought process behind this change is twofold. First, as we came together and began the early stages of revising the rule, in preparation for this meeting, we realized that we had not taken into account what external stakeholders thought was important and imperative to change. We want to hear from you on what's going on. And second, we listened and we heard you. With everything else that's going on, we came to a conclusion and we agreed that adding this to the mix as well would have just been too much at this point in time. As a department, we're going to focus our efforts on PDN implementation and a few other projects before tackling this head on. So what that means for these meetings and these work groups going forward, we are not going to have a June meeting, so you can cancel that off your schedules and give yourself back an hour and a half. We will begin the red line work later on. That date is to be determined. Please be on the lookout for any emails that will come from the home health inbox for any future updates. So I just want to let everyone know and make sure everyone's on the same page that we will not be doing any red line work specific today. This is more of a collaborative effort to get any ideas, suggestions, concerns, so that we can take this back and be ready for you guys next time. So quickly, just the very basic rule revision process. Step one are these meetings, these work groups, this collaborative effort to redline the documents. Following this, it will go through HCPUF's own clearance process. Step 3 is presenting and giving the proposed rule to the Medical Service Board for their discussion and eventual adoption. And finally, it will be the implementation of the rule itself. Thus, after that, HCPUF will provide training and any support to help implement this rule. Okay, and 1 second, getting a notice here. This meeting is view only, so we're going to take a quick little.
Paul, let's see. I think I was able to change in the controls that folks can use the chat and make comments. So Megan, if you still have a comment, excuse me, see if you can come off mute.
Hey, Megan, are you able to type anything in the chat box?
All right, try one more time. Let's see if this works.
Hooray, you fixed it.
Hey, thank you very much, Cassie. Thanks.
That was just my question. That's why I had my hand raised. I was like, we can't participate. The settings are weird.
Well, thank you for catching that. I apologize to everyone. So if there's any comments or suggestions that anyone wants to catch up on, now's the time to do so. We'll take a quick little breather here. So if anyone wants to jump in the queue or make any comments in the chat box, please do so. All right. Well, if you do have anything, everyone is more than welcome to jump in at any point in time. Next slide, please. The goals for these work groups is really the same with our last work group, is we want to openly collaborate with you, with the stakeholders, with members, with the advocates, while conducting a thorough review of our long-term home health regulations. It's been a while since they've been looked at. Well, hopefully not looked at, but at least been revised. And really with working with our participants, we want to revise language that is outdated or unclear. I want to really emphasize that. We want to make this rule easier to read in more functional formats. We will identify areas that need any editing, anything that needs rephrasing, clarification, removal, restructuring. If we need to move things around, we will. But again, we want to hear from you instead of just doing it and then presenting to you what we've already done. Next slide, please. As we go through the red line process, and again, this will be a little bit more for our follow-up meetings, please remember that we are going to be documenting any and all feedback. Again, we have folks here taking notes. We are recording this, and we want to make sure that we are capturing all your ideas and suggestions. Certain words have to be changed throughout the document. For example, client will be changed to member at all points in time. In some cases, we will have to reorganize the sections. So if we have to move things from one section to another or just change the way it flows, just so it reads a little bit easier. And finally, we will be adding new definitions, taking out some old definitions, spelling out some acronyms, and like that kind of stuff going forward. So just to let you know, those are just some very general high-level view things that we will be doing. Next slide. All right. So for the workgroup itself, again, you can follow this link here if you have downloaded the slide deck. Also, you can just Google 8.520, type in Colorado Home Health, and that should bring you straight to the rules and regulations as well. And again, we're just going to open this up as a collaborative work group. Thank you, Christine. Are there any specific items that you would like to see addressed as we start to begin this process of looking at the long-term home health rules and regulations? I'm going to go ahead and put myself on mute for a minute, and if we have any suggestions or concerns or anything you'd like to see changed, please go ahead and raise your hand.
Hi, this is Tracy Heister from the Independence Center down in Colorado Springs. So I don't know that I have anything that comes to mind to be changed. We are primarily just IHSS these days, HCBS. We have closed our skilled program, but I know these rules apply to all of us. And so that was my interest in wanting to join this work group, to just be a part of this process. So haven't gone through it enough to know what that looks like, but just to throw out my personal reasons for being here and hopes. So it is kind of hard. It does coincide with our PDPPC a few different times this year. So I'm probably going to log off of here to join my IHSS breakout there. But anyway, just wanted to throw that out there.
Well, thank you, Tracy, for being here. We appreciate your time. And yeah, once we get going on this process, again, please be on the lookout for any emails coming from the Home Health inbox when we have specific dates. What we'll do is probably 2 weeks prior to our meeting date, we will send out an agenda. We will send out exactly the red line sections we will be working on, again, and then we'll come together, collaborate, and go through those sections one by one and do the red line process live and in person. It will in person as we can get, so that everyone can see exactly what's going on and going through this process. So again, thank you for being here. Anyone else? I know the role's not perfect. All right. Thanks, Megan. And we want to make sure you are here as well. We appreciate your input and your perspective on things for sure.
So I'm going to jump in. Something that I've heard lately is that 8.520.5B, and I don't remember, I think it's down in O. It's one of the tasks for CNAs about medication reminding, and it contradicts right now what the expanded scope of the CNA is. I know that we haven't opened the home health rules in quite some time, and so there's been, COVID and changes with the public health emergency and just growth. So I would like to see that that requirement of having a CNA med certification be required for CNAs to do just medication reminders. So that's a big thing that I think we need to add or change, I guess.
Great. Thank you. Thank you, Christine.
Mm-hmm.
Go ahead, Chris.
One of the things that I'm curious about, it has to do with the definitive nature of a CNA being a skilled service provider. The paperwork, some of the paperwork that has to be turned in once we redo the CNA PARS refers to unskilled. It refers to CNA as unskilled services. It's a very old document. And I'm just wanting to see whether you guys could review that and note that, so that could be, it's not in sync with the rest of CNA being a skilled service, not as skilled as nursing, but skilled nonetheless. And it is referred to as unskilled. So just wanted to bring that up.
Yep, just having that consistency, I think, throughout any billing manual or documents that we reference. Yeah, I agree.
Yeah, and I will say one of the big things we're looking at is taking what is in the current PDN rule and make sure that mirrors long-term home health as well. Christine and her team has done a considerable amount of work on that already. So it's made it a very easy process for us to get started here. So we want to make sure the definitions align. Again, any type of wording, as you said, Chris, skilled versus unskilled. We want to make sure things are mirroring each other, so we're not reinventing the wheel here. We want to make sure that things are consistent and make sure they flow nicely. Yeah, Megan, go ahead.
Also adding that the rule currently still states that pediatric personal care can't be provided by a legally responsible adult. And my understanding is latest guidance, kind of hot off the press guidance from CMS, is saying that that is not necessarily the case, and that it can and will, through CFC, be allowed to be provided by a legally responsible adult. So it would make sense that the same would be true in the long-term home health benefit package, as well as on CFC, for the sake of consistency, if nothing else.
Yep, I agree with you. Thank you. Yeah, Irina, go ahead. Oh, I think you're on mute.
Hi.
Hi.
Hi. Thank you, guys. Again, I wanted to apologize in advance if I get disconnected. I'm traveling, but wanted to take this time to make some comments. So, in regards to, like, in alignment with what Megan said, the consistency, I think as we are going through the rules and regulation, would be very important that we find areas that may be still inconsistent with certain regulations from, Chapter 26, the home care regulations that developed by CDPHE. So we find the kind of alignment between the two. Just to give you one of examples that lots of providers ask me all the time, in the medical assistance manual in 8520, we have indication that if a patient who needs long-term services requires discharge, we have to give them a discharge notice of 30 days. In Chapter 26, it says discharge notice of 15 days. So just moments like that as we're going through, and we'll maybe start redlining things that maybe we can pay attention to, inconsistencies between the medical assistance manual and Chapter 26, just to ensure that we decrease confusion or misinterpretation of the rules among the providers as much as possible.
Yeah, I agree. And I think you bring a very excellent perspective to this as well, because you are hearing it so much. We don't hear it quite as often where we are, but if you out there on the front lines are hearing this, I think that's a great perspective to bring up. So yes, we want to make sure everything is consistent and easy to read and makes sense for everyone involved.
And then, thank you. And then one more comment. So as we know, parent CNA program in Colorado is really growing, and lots of providers just strictly focusing on that. So maybe we can incorporate, I don't know, some of the key components, maybe something that you came across, guys, and the questions that were directed to you, that maybe we can incorporate some reference to the parent CNA program in the long-term home health component as well.
Great, thank you.
Thank you.
All right, who do we have? Why don't you go ahead, Elizabeth? We'll start with you.
Great, thank you. This is Elizabeth Freudenthal. I work on Medicaid policy at Children's Hospital Colorado, and one of the massive barriers to care that we experience really is the volume of physician orders to our special care clinic associated with the Medicare conditions of participation for home health agencies. This is a huge problem. I'm not sure if there are solutions through this rulemaking process, because it is such a big, it's a super complex situation having to do with mostly the federal Medicare conditions of participation. But in short, those conditions of participation associated with home health services were really designed to support adults post-discharge who are going to recover basically with these services. But we're seeing such a growing number of young people with medical complexity whose conditions will not change. And the Medicare conditions of participation have these requirements for, I think the hardest one for us is the 90-day recertification of services. So this is not a HCPUF requirement. This is a CDPHE licensure requirement, right? And so again, I don't know if the rulemaking process is really the appropriate venue, but I wanted to voice this concern that there are lots of people being served by these programs that for whom 90 days is, you know, their conditions are going to be relatively stable or unchanging for much longer periods of time than that. And the volume of paperwork that's generated that does not provide clinical improvement or clinical oversight because people's conditions are not going to change within 90 days, or even, you know, 6 months would be ideal, really. It is such an urgent crisis for us and our teams. We're really casting our net wide for policy solutions. And so one potential policy solution through this rulemaking process would be some kind of alternative model for home health agencies to provide support for certain populations for whom a 90-day recert is not necessary. This is pie in the sky, but I wanted to bring it up. Thank you.
No, we appreciate your perspective and ideas and thoughts on the solution. So it's something we can take back and take a look at. So thank you. So I'm just looking at your comments here, Megan. Yes, definitions, we are pulling directly from PDN rules as well to make sure they match. And then unpaid family giver, that is also on our agenda, not for our agenda today, but it is on our list of things to be changed as well. So thank you. And just so everyone knows, if you don't feel like speaking, you can always put your comments or just suggestions in the chat. We are keeping note of all of those, and we'll take those directly back to our listening log as well. So all of these ideas will be documented and discussed. What else? What other things have you guys been hearing in the community in terms of talking with different providers or families? Anything else that you guys feel like you are constantly having to look up or refer to the rule about? Any other clarifying language that we could look at or provide to y'all? And sorry, I just realized I said y'all. That's the Virginia coming out in me.
This is Kate Morrison with Maxim Healthcare Services. Really grateful for the opportunity to participate here. I think just from our side, we weren't completely prepared for this kind of open-ended conversation and appreciate it a lot, but definitely look forward to, we'll do some internal conversation and come back with some written comments or be prepared for the next meeting a little bit more. Thank you.
Great. Thanks, Catherine. At the end of the slide deck, we do have a link to our feedback forum, which we'll also post in the chat as well. So if you guys do want to take some things back or present some things over the next couple of weeks, please feel free to fill out that feedback form that comes directly to our inbox, and then we will be documenting all of those ideas and suggestions as well. Oh, thank you, Christine. You beat me to it. If we want to go ahead and flip through the next two slides, just give everyone an idea of the breakdown of 8.520. Is either our definitions and goes all the way through documentation, prior authorization, reimbursement. all the way down to denial or termination services. Again, we've provided the link to this specific rule in the chat here a couple times. It is also on our home health webpage, as well as in this PowerPoint or slide deck as well. Feel free to go in and look at it. And again, if you see anything that comes up in the next week or two, feel free to either email us. You can send us back, again, things on the feedback form, or yeah, somehow let us know. Fax, apparently. If you still have faxes. Some people do, I guess. Yes, place of service, correct. Yep, got that as well, Megan. Thank you. And Dulce, would you mind going back one slide? Thanks. When we eventually do get to the actual redlining process, I would prefer, and again, you can let me know, doing this in order so that we're not jumping and skipping around several different sections. So ideally, we would look at definitions, client eligibility, and probably provider eligibility in the first meeting, and then go to, covered services, service types in the second meeting. So let's assume that's probably going to be our train of thought and how the general work is going in order, just so it doesn't get too confusing and we're not jumping around too much. But again, prior to getting these meetings started, we will send out an agenda and exactly what we will be redlining 2 weeks prior to the first meeting, and you will have plenty of advance notice before that.
All right, this is Megan Bowser with Family Voices again. One of the other things that occurred to me that would be helpful in the process is looking at having some utilization data collected when looking through these rules. I think a big sign that a rule is not serving its intended purpose is if the utilization is exceedingly low, like pediatric personal care, for example. But I'm sure there are other things in there that just having some of that data collected on what in this long-term home health is being utilized and by what percentage of clients might be good information to know where there may be pain points that we don't think of immediately.
That's a great idea. Thank you.
I agree. This is Elizabeth from Children's. I agree with that. That's an awesome suggestion. And I would also appreciate bringing in prior authorization data to the extent that that's possible. I know that that's complicated because of the off and on of the prior authorizations, but that could be helpful as well. Thank you.
I'm going to go ahead and advance to the next 2 slides, please. Okay. What we're going to do here, I certainly want to be respectful of everyone's time. I will stay on this meeting for about another 30 minutes or so in case people pop in late or if there's any suggestions or comments that come in. I know there's some folks who want to jump over to PD, PCP. That's going on right now as well. Just to kind of recap things we've heard is we really want to make sure we are being consistent with our terminology, with the language, and with definitions. So we just know we are pulling from PDN, taking a lot of Christine's work that she's already done and made this very easy for us, or hopefully easy going forward. Looking at different terminology like the legal responsible adult, looking at different things we can do to kind of help out Elizabeth, like what you said, with the extensive amount of paperwork and MD orders, and then trying to pull in some utilization data and maybe some PAR data as well to help out. Again, if there are any other questions or concerns, I'm happy to stay on this call for anyone. You can utilize the chat or utilize the feedback form, which has been posted. But again, I do appreciate everyone's time, and yeah, feel free to get a hold of us at any point in time, either by email or the form or however else you'd like to get a hold of us. Great. Thank you, Catherine. We appreciate it. You can probably go ahead to the next slide. I think it's just comments and thank you. Yep. Yeah, Chris, go ahead.
Hi, Paul. I don't know if this is really within the confines of the goals of this meeting, but I think that there's always a question of, what's written, how it's understood, and there sometimes seems to me to be a different question, and that has to do with how does KeyPro read it. And that affects, of course, all of the families. It affects the agencies. I mean, KeyPro's take on what these things mean is very important. And when we're talking about collecting data to understand what is and what isn't understood and how it's understood, it would be super interesting to me to see of the people when we start doing PARs again, of the people who I would like to see a comparison between PAR submissions and the diagnoses of those individuals and PAR denials and approvals and the diagnoses of those people. I'd like to have some understanding about an example would be something becomes a skilled service when the patient is unable to direct their own care or participate in their own care. In the past, we've seen a lot of diagnoses that are IDD involved that don't make it past KeyPro. Like it used to be that pretty much everybody with autism got denied CNA services. They weren't considered medical, the needs of the autistic community. I'd like to know what's going to happen going forward in that definition of whether or not you can participate in your own care, and whether that's just a physical limitation that causes that, or whether that's an intellectual limitation that causes that. I'd like to know how KeyPro is reading that rule.
That's a great suggestion. We can reach out to, because it's a Centra now, because I call it KeyPro probably 10 times a day. I'm looking at how, not only how they are interpreting our rules, but I think it would be a great idea to invite them to these meetings as well. I don't know if they would be willing to send a representative, but I'd like to get a little more involvement from not only them, but we have folks from CCQI here, but maybe CDPHE, and also when we start this process, we're going to get the folks from acute home health on the meeting as well, so we can get some questions and make sure they are okay with what we're changing. But yeah, no, I appreciate the suggestion, and we will document that and take it back to the team. So thank you.
Thank you, Paul.
All right, I'm going to be on the meeting. I'm just going to take a look at the feedback form. Apparently it is locking people out, so I'm going to be paying attention to the screen here, but I'm still available for questions if anyone has any.